Okay, this is the airway management and ventilation section of the EMT Paramedic review. So one thing to keep in mind about airway management and ventilation is that this is the most critical step in the initial assessment of every patient that you'll encounter. Some anatomy about the lower airway is the trachea, which is a C-shaped cartilage. It's just lines of C-shaped cartilage from high to low, essentially. The bronchi is the main stem that leads into the bronchioles, which branch out into these smaller rings. A unique property of this is just the stimulation, how easily stimulated they are by different drugs. Alveoli, one thing to keep in mind is that that's where the perfusion occurs, diffusion of oxygen and CO2 and other properties of air, I guess. The diffusion occurs right there. So one thing to keep in mind, if you know what COPD is the importance to have surfactant, because the coating of surfactant keeps the alveoli from collapsing on themselves or shutting air or locking air into the area. It just keeps alveoli from collapsing. Another one is pleura, or the pleura space. You've got the parietal and visceral area. If you don't know what that is, parietal is outer, visceral is inner. And one thing to keep in mind between pediatric and adult airways is that pediatric they just have a smaller jaw, larger tongue, and the epiglottitis. The epiglottis is rounder and floppier than that of an adult, and do keep in mind that the narrowest part of the pediatric airway is the cricoid cartilage area. That's good and bad-ish. It's bad because in terms of air movement, that's your point of impedance, but in terms of endotracheal tube, you'll get a pretty good seat or a good seal around that due to the narrow space of that. It depends which way you look at it, really. But the respiration, as far as respiration goes, is that's where the exchange of respiration is the exchange of gases between a living organism and its environment. So if your environment is filled with oxygen, you're going to be diffusing oxygen. If it's carbon monoxide, outside of the properties, the binding properties being greater than oxygen, the binding affinity of monoxide, that's the environment or the respiration that you're going to be doing is carbon monoxide. So, outside of that, that's all it is. Ventilation is the mechanical process that moves the air in and out of the lungs. Pulmonary circulation is the perfusion of oxygen and carbon dioxide. Diffusion, I've been saying that without defining it, but diffusion is the movement of gas from an area of higher concentration to an area of a lower concentration, kind of like where sodium goes, water follows, that kind of stuff. I'm trying to think of another different type of example for diffusion. I guess if you separate, or in a tea bag, you got a concentration of tea within the bag, and it diffuses across that we'll call it a membrane, and it diffuses within the water. Same concept-ish is what you could call that. I'm trying to give you all a visual example, but that's what it is. So where was I? Anyways, diffusion is super important, because if that that difference isn't occurring, then you're not going to get the concentration change to perfuse the surrounding tissue. So measuring oxygen and carbon dioxide levels is, the partial pressure is the pressure exerted by each component in the gas mixture. So, normal arterial pressure, which is just PA for short. Oxygen PaO2 equals like 100 torr, where the average is like 80 to 100, and the carbon dioxide or PaCO2 is 35 to 45. with the average being 40 is super important if you're going to be intubating and you're going to have a capnography hooked up to your patient. So, factors affecting oxygen concentration in the blood can include decreased hemoglobin concentration, like anemia and type of stuff like that. Inadequate alveolar ventilation. That's just, maybe your tidal volume is not good enough. Maybe you've got an obstruction. Decreased diffusion across the pulmonary membrane. When diffusion distance is increased and the pulmonary membrane changes. You've also got ventilation perfusion mismatch occurring. That's when a portion of the alveolar collapses. That can cause a little bit of a mismatch in the alveolar wall. So, factors affecting carbon dioxide concentrations in the blood. Obviously, hyperventilation lowers CO2 levels due to the increased respiratory rate or deeper respirations. Then always have to be associated with faster, just deeper. So, this can cause CO2 production. Causes an increase in CO2 production. What am I saying? The causes of increased CO2 production include fever, muscle exertion, shivering, obviously because of muscle exertion, metabolic processes resulting in the formation of metabolic acids. Basically, any type of exercise will increase CO2, and that's, if you're familiar with like the Krebs cycle and just how metabolic, just those chemical reactions, how those occur and what are the byproducts, then you're familiar with how CO2 concentrations can increase. And if you're familiar with buffers, then kudos, that's even better because your body is filled with buffers to reduce the yo-yoing effects of CO2 and other concentrations of other stuff, I guess, CO2 and whatever. Where was I? So if a patient has like a PaCO2 of 30, you could consider that to be alkalytic or alkalotic, however you want to pronounce it. So the only way to correct that is to decrease the tidal volume or decrease the respiratory rate. Maybe even a combination of both of them. So decreased CO2 elimination results from decreased alveolar ventilation, so respiratory depression, airway obstruction, respiratory muscle impairment, or obstructive diseases like COPD and whatnot. That all can increase CO2 within the blood. So regulation of respiration is the next thing I want to talk about. The respiratory rate. The involuntary respiratory rate, however, can be voluntarily controlled. The chemical and physical mechanisms that provide the involuntary impulse is kind of the correcting mechanism for any breathing irregularities. So, over time, if you're a normal, healthy adult, your breathing just, auto-corrects by itself. So, some of the things that senses those changes is your chemoreceptors, and those usually they're located in your carotid bodies, arc of the aorta, and the medulla complex, or the medulla. You also have baroreceptors in your carotid artery. Those are very important for regulating blood pressure. Those are usually stimulated by decreased in PaO2, so oxygen concentration within the blood, and increases in PaCO2 and decreases in pH. So the cerebral spinal fluid, the CSF, pH is primarily controlled by the respiratory center. So one thing to consider from that is that the main respiratory center is the medulla. So the neurons within the medulla initiate the impulse that produce respiration. Okay, so the apneustic center assumes respiratory control if the medulla fails to initiate impulses, kind of how your heart has those fail-safe measures from like the SA node to the AV node, whatever. It's kind of the same concept. If medulla fails, then the apneustic center assumes respiratory control. Impulses are pneumotaxic center controls respiratory. Um, what else? Hypoxemia is a profound stimulus of the respiration in a normal individual. So the hypoxic drive increases the respiratory stimulation in people with chronic respiratory disease. So that means that if you have COPD, the chances of you driving your respiratory rate is most likely going to fall upon the hypoxic drive. Whereas hypoxemia is the stimulating or normalizing factor within normal individuals. So keep that in mind with patients with COPD or something like that. The stretch receptor, is the Herring-Burr reflex. I think I brought that up earlier, but prevents overexpansion of the lungs. It's located around the alveoli. This is super important to keep overinflation and increasing your chances of pneumothoraxes and stuff like that. So normal respiratory rates in adults is 12 to 20. Pediatrics is 18 to 24, and infants is 40 to 60. Do bear in mind that this can change between individuals, but those are your normal averages. Dead space volume is VD, so amount of gas and tidal volume that remains in the airway. So approximately 150 milliliters in adult males is the average dead space air, that doesn't reach the alveoli. Basically, the amount of gas that doesn't go through that diffusion process. So if you're making someone breathe, an adult male, if you're going 150 milliliters, you're essentially not doing anything, is what you're doing, because you're just moving that dead space. Okay, so total lung capacity is TLC, and that's the total lung capacity of the average male would be 6 liters. Tidal volume is the average volume of the gas inhaled and exhaled in one respiratory cycle. So for the average adult male, that's 500 milliliters. And inspiratory reserve volume is IRV, is the amount of air that can be maximally inhaled after a normal inspiration. So from a normal tidal volume, you're going to get, and you minus the maximum volume of inspiration, you minus those two together, you get the IRV. Okay, so respiratory problems, airway obstruction. The tongue is the most common cause of airway obstructions, snoring, that kind of stuff. If you hear snoring, then the tongue is, moving posteriorly, especially if they're laying supine. But other causes of airway obstruction is just, basic foreign bodies, trauma, laryngeal spasms, edema, aspirations, that kind of stuff. And respiratory system assessment. As far as assessment goes, it's pretty basic. Is the airway open? Is breathing adequate? Look, listen, and feel. If the patient is not breathing, open the airway and assess ventilations as necessary. If they're not breathing, is there a reason they're not breathing? Maybe they choked on something. If you've got your BVM hooked up and you're trying to breathe for them, you're finding that there's resistance. Maybe you got an obstruction. You need to consider cricothyrotomy because maybe you're having too hard a time removing that obstruction. Or maybe an endotracheal tube. Whatever you do, I've also heard that sometimes obstructions, you just got to push them through the bronchial cord, the bronchial, especially if the obstruction is below the cricothyroid membrane. It's not going to do you any good if that obstruction happens to be below that. You're not going to be breathing any better than you were if it was above that. So sometimes you got to put your ET tube in there and try and push it lower, because you might push it past the carina, because you might even get some respiration. One lung is better than no lungs, even though you're risking some form of infection from that foreign body. They'll have to surgically remove it, but at least there is a chance that some diffusion will occur. So, where was I? As far as physical examination, inspect the skin, color, patient's position, if they're tripoding or not, dyspnea, difficulty breathing, modified forms of respirations, like I said, tripoding, nasal flaring, are they using their intercostal muscle, are they retracting those, rate pattern, auscultation, listen to the mouth and nose for adequate air movement, listen to with your stethoscope for normal and abnormal air movement within the lungs, position for auscultation of the breath sounds, both anterior, posterior, and I usually also do mid-axillary. And abnormal respiratory patterns, the Kussmaul respiration you should be familiar with. Kussmaul is deep, slow, or rapid. Gasping, common in diabetic ketoacidosis. So that's going to look like someone who just got done running. If it's rapid, it's just going to be deep breathing. Cheyne-Stokes respirations is progressively deeper, faster breathing, alternating gradually with shallow, slower breathing. That's usually a brainstem injury, kind of like a stroke or something like that. Or a fall, traumatic brain injury. So that's Cheyne-Stokes. That's just a patternless like and then slowing back down, and that's it. So that's Cheyne-Stokes. And then agonal respirations. Agonal respirations, it's also known as like death breathing, basically. So just shallow, slow, and infrequent respirations indicating brain anoxia. So that's just your brain dying, essentially, is no longer controlling or having effective control of breathing. So so that's agonal breathing. And disruptions in ventilations, some cause of that is your nervous system, trauma, poisoning or overdose, and diseases. Airway sounds you should be familiar with is stridor, wheezing, rails, rhonchi, snoring, and crackles. And palpate the chest wall for tenderness, symmetry, abnormal motions, crepitus, and subcutaneous emphysema. If you don't know what subcutaneous emphysema is, just air under the skin. It sounds like popcorn when you press on it. Other types of monitoring devices, non-invasive respiratory monitoring, colorimetric end tidal CO2 detector, so gold is good, purple bad. Electronic end tidal CO2 detector, like your capnography monitor, pulse oximeter, esophageal detector device. If the bowl is not, for example, like if you're using a bulb and it doesn't fill immediately, then the bulb is probably in the gastric area. Manual airway maneuvers, this you should be familiar with. Head tilt chin lift, modified jaw thrust in trauma, jaw thrust maneuver, what is it? Selkirk maneuver. There we go. Selkirk maneuvers is just cricoid pressure from, if they're laying supine, you push down on the cricoid. And jaw lift maneuver is also another one. Basic mechanical airway that you should be considering is nasopharyngeal airways on non-head trauma patients or any like type of bleeding associated with that. Oropharyngeal airways, that one's pretty self-explanatory. Insert oropharyngeal airway with the tip palate and rotate airway 180 degrees into position. So you're going to start with it upside down, at least in adults. Now remember that in pediatrics you're going to start, I think it's 6 and under or something like that. I don't remember the exact number. But in infants you're going to want to start in the normal position and then just kind of push it in. God, I'm trying to find the... whatever. It's like 6 or less or something. If you want to know, just go back one video and it's in there. What was I gonna do? Oh yeah. And then advanced airway management is going to be like your endotracheal intubations. So that's the preferred method in terms of an airway management in the pre-hospital area. You also have like different methods, whether it's like a king tube or or any other ones. you've got like 4 other ones to choose from, but as far as ET tube, that one is the most preferred method because of the good seal. But you have to have experience with that to be effective with it. And let's see. Laryngoscopes, the blades that you need to consider, like the Macintosh blade and the Vallecula and Miller, those lift up the epiglottis. The straight blade go in front of the epiglottitis, while the Miller blade goes into the vallecula. And the vallecula is that space between the epiglottis and the tongue, so keep that in mind. The endotracheal intubation indicators is respiratory or cardiac arrest, unconsciousness, risk of aspirations, obstructions due to foreign bodies, trauma, burns, or asphyxiation, anaphylaxis. Respiratory extermus due to disease, pneumothorax, hemopneumothorax with respiratory difficulty. Do bear in mind, like if they're holding a good, volume, and they have a pneumothorax or something, or a suspected pneumothorax, but they're still exchanging that oxygen, that's not grounds to intubate. So use logic there. So where am I? And then so the advantages of an endotracheal intubation is the fact that it isolates the trachea from any obstructions or airway obstructions or anything like that. So it impedes gastric distension. Because you're eliminating that even being an option. You'd have to perforate the trachea to even have that be an option. Anatomically speaking, of course. So it's difficult to do this because you need to have direct visualization of the vocal cords, which can be difficult depending on your patient. So you do need to bypass the upper airway function of warming, and so filtering and humidifying the inhaled air would be a good idea, especially if they're going to be on it for a chronic or extended amount of time. In EMS, that's not too much a concern because of the urgency of the situation. But once they get to the hospital, I'm sure that that they would transfer to a humidified regulator or something like that. So continuously recheck and reconfirm the placement of the endotracheal tube is a fantastic idea. Especially if you are getting decreased resistance upon on inspiration, because you are also fighting the weight of the body and the overall elasticity of the lungs when you are breathing for them, so you will be able to feel it. So if all of a sudden it gets easy, it's probably because it dislodged. So keep confirming. What I would do if you have the option is to continuously have capnography on there, because if you're getting some decreased CO2 readings, then that might be either because you're breathing too much or because you're dislodging your tube. You'll also get some associated decreased waves associated with that because you're getting less volume moving in and out. Well, there's a number of confirmation methods to this. Auscultating, looking. Dude, there's like so many. Let's see, where are we? Put my notes down here. Okay, so other intubation devices, like I was mentioning earlier, is the combi tube, laryngeal mask airway, the pharyngeal tracheal lumen airway, esophageal gastric tube, and esophageal obturator airway, which is EOA for short. Okay, so the only indication for a surgical airway is the inability to establish an airway by any other methods. So I briefly touched on that, but jet ventilation with a needle cricothyrotomy, so you should be using a 14 gauge needle with positive pressure. Anatomical landmark for cricothyrotomy, you should be between the crico cartilage and the thyroid cartilage. It's just that space. If you identify your Adam's apple, just go right below it and you should find that soft tissue, that membrane right there. That's a really good opening for that. The procedure to make that cricothyrotomy is it depends on what you have. You can have a cric kit, where you just clean the area and push the needle in, or you can have the incision method, which is the 1 centimeter horizontal incision through the cricothyroid membrane. And yeah, there's different methods. I'm not going to verbally explain that because you have to watch a video, so just watch a video for that. Tracheostomy cannula. Patients with some stomatitis, they have had a laryngectomy or a tracheostomy, breathe through a stoma. So there are often other secretions and other crap like that. You can get that buildup, like that mucus buildup in there. So sometimes they have a hard time breathing because of that mucus buildup. So some suctioning techniques you should be aware of outside of wearing gloves, eyewear, goggles, face masks, whatever. Is you do need to pre-oxygenate the patient, determine the depth of the catheter insertion with the suction or the insert the catheter. And when I say catheter, I do mean the suction catheter. So turn on the suction and suction while removing the catheters for no more than 10 seconds. And then hyperventilate the patient. So oxygenation, the oxygen supply on the regulator, green, chrome, white, 2-5 pin index. The oxidizer and the oxygen label just calculate to how long the oxygen tank will last. So man, I do want to go over the formula, but it's kind of hard to verbalize. Anyway, so let's just talk about oxygen, the oxygen delivery devices in terms of percentages of the oxygen that's delivered. So in terms of a nasal cannula, if they're breathing through their nose, 40%. Simple face mask at 40 to 60%. This will matter if depending on what concentration or liters per minute you do set your method at. The Venturi mask at for a non-rebreather is going to be 80 to 95%. It's never going to be like 100%, but unless you use like a BVM with a reservoir or something like that. So just do bear that in mind. Ventilation methods: mouth to mouth, mouth to nose, bag valve device, demand valve device, automatic transport ventilator. So when venting when ventilating a patient, just be conscious of the tidal volume. It is 5 to 10 cc's per kilogram, so you can kind of gauge how much you're giving just based on the size of the BVM you're using and how deeply you're pressing on it. So just look at your averages and stuff like that. You can kind of ballpark that one. And I say ballpark because you have so many methods of assuring adequate ventilation, so you can adjust on the fly. There is no set standard for everyone, so just breathe for your patient per your patient's need. Adult respiratory distress syndrome, or ARDS. Causes of this is like sepsis, aspiration, pneumonia, pulmonary injury, burns inhalation injury, drugs, high altitude, hypothermia. Some pathophysiology you should consider is that it has a high mortality. It's got multiple organ failures, affects the interstitial fluid. It causes increase in fluid in the interstitial spaces, which can disrupt the diffusion and perfusion within the lungs, or the anatomy of the alveoli, the junction between those capillaries and alveoli. So where was I? Oh yeah, and how do you manage adult respiratory distress symptoms? It's literally just symptom management in a sense. Manage the underlying condition, provide some supplemental oxygen, support respiratory effort, provide some positive pressure ventilation if you can, if that's an option, if the patient tolerates it. You can have the patient be completely conscious and just help him breathe with a BVM. Monitor the cardiac rhythms and vital signs. Consider medications you can give, like corticosteroids, for example, that can help open up the bronchioles a little bit. Obstructive lung diseases. Some types that you might want to be concerned with is emphysema, chronic bronchitis, and asthma. Causes is obviously like genetic disposition, smoking, other risk factors like living in the city, or work hazards, stuff like that. Like, where are you working, where are you at home, whatever. Emphysema, a really good one to know the pathophysiology behind this one is the exposure to noxious substances. The exposure that results in the destruction of the walls of the alveoli. That's called atelectasis. This is a term that I have seen plenty of times on the test. That's just one of those causes for that poor perfusion. That atelectasis is essentially destroying the walls of the alveoli, which reduces the effectiveness of that diffusion. Weakness in the walls of the small bronchioles and results in the increased residual volume. The loss of the elasticity causes the increased pressure, and the right-sided heart failure or failure cor pulmonae, polycythemia, and increased risk for infection and dysrhythmia. So, if you don't know what polycythemia is, it's just a lot of red blood cells, higher than normal. So, they can look a little red in nature because they have such a high red blood cell count. Because of that decreased perfusion, you need to combat that decreased perfusion with a higher count of red blood cells to increase the oxygen, or to meet the demand of oxygen by your peripheral. What do you call it? Anyway, the just your peripheral cells, stuff that needs oxygen, shit, like your muscles, whatever, other organs, and then your assessment for emphysema. That's pretty simple. Typically, we call them barrel-chested, which means they have a big chest because of all that air that's kind of locked in there, They'll have a prolonged expiration and rapid rest phase. They'll have thin pink skin due to the extra red blood cell, like I said earlier, and a hypertrophy of the accessory muscles, like pink puffers. The accessory muscles I'm talking about is going to be like the ribs, the abdomen, stuff like that. Anything that helps move more air outside of that of the diaphragm. Chronic bronchitis. Chronic bronchitis, in terms of pathophysiology, is a result from an increase in the mucus secreting cells in the respiratory tree. Alveoli relatively unaffected. The decreased alveolar ventilation. So the history of this is just frequent respiratory infections, productive cough. Typically, a smoker. Has been going on for years, So physical exam on this one. Often overweight. You'll have some rhonchi present on auscultation because of just that all that air that's in there. The jugular vein distension is common. Ankle edema. Hepatic congestion, like blue bloater. That's self-explanatory because they're just living in that constant hypoxic state, basically, and they're typically fat, so blue bloater. Bronchitis and emphysema management. Let's see. Outside of support breathing, there's not much to it outside of taking care of them like a normal patient. So maintain the airway, support their breathing, find position of comfort, because typically they can have some heart issues, especially with the smoking history and whatnot. monitor oxygen saturation. Now, you should keep in mind that some of these folks, especially with emphysema, can run on the hypoxic drive and stuff like that, or chronic bronchitis or emphysema. So, any type of breathing issue, they can run on the hypoxic drive depending on the situation. But be prepared to ventilate or intubate. Cardiac rhythm, and you should consider an IV access, especially if you're worried about an intubation. Administer medications if needed, bronchodilators and corticosteroids and stuff like that. Another common one, becoming more and more common, is asthma. So the pathophysiology behind that one is chronic inflammatory disease that results in widespread but variable airflow obstruction. So the airway just becomes hyper-responsive. It's induced by a trigger which can vary by individuals, whether it's a certain pollen or a different allergy or whatever. So the trigger is usually secondary to the release of a histamine. And, as you know, histamines can cause bronchial constriction, bronchial edema. 6 to 8 hours later, the immune system cells invade the bronchial mucosa, and they can cause additional edema, and that can further that can cause further problems down the line, just because of the natural progression of the body's reaction to these foreign overreactive objects, I suppose you could call it. But the physical examination would be just in terms of the assessment, would present with signs that include dyspnea. You can have some wheezing, you can have some coughing. Wheezing, I do want you to keep in mind that wheezing is not always present in all asthmatic patients, but speech may be limited to 1 or 2 consecutive words because of that effort that they just need to keep breathing. That's all they can focus on. So look for hyperinflation of the chest and accessory muscle use. Carefully auscultate the breath sounds and measure peak expiratory flow rate. You may not stop breathing because of decreased lung capacity, and that's the decreased lung capacity is secondary to the inflamed bronchiole. And bronchiole is, like if you have more or rather less area for the air to go through their total volume that they're inspirating and expirating is obviously going to be decreased. So that can tell you a lot about what's going on here. But as far as management and treatment goals, just try to correct that hypoxia by addressing those breathing problems. Try to reverse that bronchospasm. Try to reduce that inflammation. But in terms of airway, it's all maintenance. Support the breathing, high flow oxygen or assisted ventilations as indicated. Assisting their ventilations is going to reduce their anxiety because they don't have to work so hard, and that helps decrease the oxygen demand on those accessory muscles. Can be very helpful because that sense of impending doom alongside your presence can really decrease the symptoms of having an asthmatic attack. So, these patients you're going to want to put on ECG, monitor their cardiac rhythm. Obviously, for these, always establish an IV line. You don't know what's going to happen. So, as far as medication goes, beta agonist is going to be your best friend. Ipratropium bromide, corticosteroids, that kind of stuff. Status asthmaticus, that's going to be a very severe form where it's essentially just a prolonged attack that cannot be broken by bronchodilators. So your medications are going to have no effect on this. This is, an indication of this is just insanely diminished breath sounds. Recognize imminent respiratory arrest. You should recognize imminent respiratory arrest just because of the nature of the development of this. So aggressively manage the airway and breathing, and transport immediately. Get to the hospital as fast as possible because he's going to need that ALS support. So asthma in children, it's pretty common. Pathophysiology and the management are similar. Just adjust medication dosages as needed for children. It's pretty self-explanatory. Usually children go by micrograms or milligrams per kilogram. That's how we separate them. But upper respiratory infections or URI, the patient complaint is usually um, the frequent patient complaint, common pediatric complaint, and then rarely life-threatening. Pathophysiology, including the URI, is frequently caused by viral or bacterial infection, obviously. Yeah. So affect multiple parts of the upper airway, typically resolves after several days of the symptoms. And I am talking about for example, like epiglottitis or something. Sometimes that goes away on its own. Sometimes you need some help from the doctors to remove that inflammation, because it can get so bad that it reduces your ability to breathe. Breathing in cold air has been known to help a little bit, but pneumonia, if you don't know what pneumonia is, then problem, but that's just an infection in the lungs. Problem in the immune suppressant patients, like AIDS, HIV, that kind of stuff. In terms of pathophysiology, it's usually bacterial or infection, obviously. Hospital acquired versus community acquired, there's some different, like whether it's nosocomial or something. Infections can be spread throughout the lungs, so this can cause some alveolar collapse, and that if it progresses for a long time, it can result in a ventilation disorder, chronic ventilation disorder, especially if it's prolonged so long that it causes some lung tissue damage or something. The management for pneumonia is really just maintaining the airway, supported with breathing, high flow oxygen. You see how all of this kind of falls into the same thing, except for like a minor change. Monitor vital signs, establish an IV access, avoid fluid overload. Because those lungs are already strained, you don't want to put too much fluids in them. But as far as medications that you should be giving to them, unless they're suffering some type of inflammation, antibiotics, antipyretics, and beta agonists is what you're going to want to give. You can give these in pre-hospital, but antibiotics is not something that paramedics can give for now. Leave that to the doctors, because they do have to identify what kind of bacterial infection that they're dealing with, if it's bacterial or viral. If it's viral, giving antibiotics can make things worse. So lung cancer, pathophysiology behind that is the majority are just caused by carcinogens secondary to smoking cigarettes. This is not rocket science. Occupational exposure is also an issue. The firemen that were working on the cleanup at 9/11, all that asbestos increases the chances of lung cancer. So may start elsewhere and spread to the lungs. High mortality rate. Adenocarcinoma, epidermal, small cell and large cell carcinomas. Those are all the different types of lung cancers that they can get. This isn't something you're going to be questioned on in the test, but toxic inhalations, pathophysiology behind the different ones is really going to depend on the kind of irritant, especially in the long term. But acute reactions, if you inhale heated air, then you'll have like burns along the airway, chemical irritants and steam, airway obstructions due to edema and laryngospasms because of those objects or liquids or air. That's just the natural physiological response from the body. And let's see what else we got. So the assessment for that is pretty basic, same thing. Focused history and physical exam. You're going to want to know exactly what was the source. Sample and OPQRST history, determining the nature of the substance and the length of the exposure. That's going to be very important, because the longer the exposure, the worse the condition. Management: ensure scene safety. Enter a scene only if properly trained and equipped. Remove the patient from the toxic environment and maintain the airway. And then the early aggressive management may be indicated. So support breathing, establish an IV, and transport promptly. Especially if it's hot air inhalation, that the alveolars tend to not react well to burning air, and it really messes up the surfactant and alveolar, the ability to just diffuse oxygen. So high flow oxygen and PPV is obviously indicated for this type of patient. Carbon monoxide inhalation. Carbon monoxide, one thing you do have to keep in mind is that it's an odorless, colorless gas. So if your patient was at risk, you could also be at risk. So this is very important. So it's usually a result of the combustion of carbon-containing compounds. If you have like a gas heater or something. But most common places are going to be like auto shops, mines, and poorly ventilated homes, stuff like that. It can be hazardous to rescuers or EMTs. But the pathophysiology behind this is, like I stated, it has like a 200 300 time affinity over that of oxygen. So if you have oxygen and monoxide, your hemoglobin is going to bind with carbon monoxide over O2. Okay, so if you're in there doing assessing your patient and you've got these symptoms, you may want to consider an emergency evacuation. Let's see, where are we? Outside of, in terms of treatment, it's pretty self-explanatory. Ensure the scene is safe and enter the scene only if the properly trained equipment, and it's the same stuff. Some signs and symptoms of this is just determining the source and the length of the exposure. Obviously, if they've been living in there for a long time and they get headaches every day when they're at home or even at work, it could be the exposure being prolonged at a low dose over a long time. So, no loss of consciousness, but still presenting with the common, sick building syndrome, if you would call it that. But usually it's presence of a headache, confusion, agitation, lack of coordination, loss of consciousness, and seizures. So, if you've got 100% on the SpO2, that is also one to consider because of that high affinity to it. You'll have 100% on that O2, and you'll have a high affinity over the O2, and they'll typically be very, very red in terms of skin condition. And, alright, what are we at? Pulmonary embolisms. Pulmonary embolisms are pretty dangerous in terms of pathophysiology. We got an obstruction of the pulmonary artery. So typically they occurs from the right heart. Okay, just because the way that the anatomical direction, what am I saying? The anatomical direction of the blood flow yields a higher probability occurring on the right side of the heart, if you will. The emboli can be air, it can be thrombus, fat, it can be amniotic. Foreign bodies may also cause an emboli. From a recent surgery. Anything can be considered an emboli, really. But risk factors: recent surgery, long bone fractures, pregnancies, pregnant or postpartum, oral contraceptive use, tobacco use, IDDM, PE, that kind of stuff, and then assessment, just your normal focused history and physical examination, sample RPQ, RSD history, presence of risk factors, if they are present with those risk factors, you can more accurately increase your probability of making the correct diagnosis. So unexplained tachycardia can kind of point you in the right direction, because if they get tachycardia with no real explanation, and you've ruled out dysrhythmias or anything like that, then PE could be one to consider. So the sudden onset of severe dyspnea and pain, and cough, often red tinged because of that pressure. So physical examination, the anxiety and syncope and diaphoretic, JVD, the hypotension, so there'll be warm and swollen extremities because of that, the way that the heart is working. The swollen extremities, that's going to be, I would consider a little bit of a later sign, but, the management, as far as management goes, it's similar to all the other ones. Maintain the airway, support the breathing, high flow oxygen. Don't forget the high flow oxygen. Or assist ventilation as indicated. Intubation may be indicated. If it's a real bad PE, then they're going to be respiratory. Their respiratory system may be compromised completely. Establish IV access, should be obvious. Monitor vital signs closely and transport to the appropriate facility. So obviously you're not going to go to a minute clinic. But next is going to be spontaneous pneumothorax. So a pneumothorax is just the usually occurs in the absence of blunt or penetrating trauma. That's kind of where it gets its name from, spontaneous. There's no real reason. It's common with people who are getting symptoms of pleurisy and stuff like that, which is just pain associated with decreased pleural lubrication between the lungs and the chest wall. That wear and tear can end up opening up some of those alveoli and cause some subcutaneous emphysema, which can ultimately result into spontaneous pneumothorax. But yeah, some risk factors is just young, tall, skinny, lanky, and usually men. If some tall runner, says he's having a hard time breathing and stuff is hurting and stuff like that, you should, rule out, any heart conditions, obviously, but you should also have spontaneous pneumothorax in mind. In terms of assessment, focused history, sample OPQRST history again. Presence of the risk factor, rapid onset of symptoms, sharp pleuralytic chest or shoulder pain, and then often precipitated by coughing or lifting. Okay, and then in terms of physical examination, decreased or absent breath sounds on the affected side, tachypnea, which is just fast breathing, diaphoresis, and pallor condition. In terms of management, it's pretty much follows the same thing outside of some treatments. So obviously maintain an airway, support breathing, monitor for tension pneumothorax, and I'll get into tension pneumo in here in a second. But the pleural decompression may be indicated if the patient becomes cyanotic. So don't just give someone a pleural decompression. If you're not familiar with that, is when you stick a needle on the anterior side of the chest, usually large bore, past the intercostal muscle and into the chest wall to relieve the air within the chest wall. I'm not going to go into identifying landmarks yet because, again, that's going to need some visualization. But, cyanotic, hypoxic, and difficulty in ventilated patients, JVD and tracheal deviation always from the affected side, which makes sense because if the airway is if the air is taking and pushing on the lung, then obviously the trachea is going to move away from the affected side. So hyperventilation syndrome is, the assessment on that is outside of, focused history, focused physical examination, sample OPQRST. But, it's going to be usually associated with fatigue, nervousness, dizziness, dyspnea, chest pain, numbness and tingling in the hands, mouth and feet. So presence of tachypnea and tachycardia, spasms in the fingers and feet. So management of that is going to be maintaining the airway, supporting the breathing, providing high flow oxygen or assist ventilations as indicated. But do not allow the patient to rebreathe exhaled air. You know how some people have anxiety and they breathe into a brown bag? Don't let them do that because that's just going to make the condition worse because of how physiology works. They need that oxygen. They don't need to be breathing in more CO2. But so CNS dysfunction or central nervous system dysfunction, the pathophys behind that. So, causes can include the traumatic and atraumatic brain injuries, like tumors and drugs and whatever. And the assessment for that is just evaluating the potentially treatable causes. So, if they're on a narcotic drug overdose or a CNS trauma. Just if it's a narcotic overdose, try to reverse that narcotic overdose, or deal with whatever it is, like Narcan or something. CNS trauma is just if they got a bump on their head, they hit their head, and then they have some increased cranial pressure or whatnot. So all that can cause some of the CNS dysfunction. So anyway, carefully evaluate their breathing pattern, because that can give you some hints onto how far along they are into their issue, I guess. Because like I said earlier, different types of breathing can indicate different types of issues. So if he doesn't have something like God, I'm drawing a blank here. God, I forgot the name of it. But if he doesn't have something like deep and fast breathing, then you can rule out diabetic ketoacidosis. Where am I? Yeah. Okay. So, anyways, as far as management goes, follow general management principles, maintain the airway, and support breathing. Use cervical spine precautions if indicated. Moving on to dysfunction of the spinal cord, nerves, and or respiratory muscles. Pathophys behind that is going to be like PNS problems. Affecting the respiratory function may include trauma, polio, myasthenia gravis, viral infections, tumors. So, assessment, rule out traumatic injury, and assess for numbness, pains, and sign of PNS dysfunction. If they've got tingling in the fingers and, their breathing is adequate and all that, maybe they have some form of peripheral neuropathy or something. There could be some dysfunction, especially if there's no related case of untreated diabetes. So as far as management goes, follow the general management principle. Maintain their airway and support their breathing. Use cervical spine precaution if needed. But that pretty much sums up not everything, but a good portion of ventilatory management in terms of disease management and how to take care of all of that. Next is going to be the fun stuff like cardiology. So stand by for that.